We just wanted to ask you a couple of questions given the Biden administration changes to Medicare Advantage and your opinion on them, and if you think that these changes in Medicare Advantage payments have been portrayed as potentially harmful to seniors. Given the introduction of the ACO Primary Care Flex model, how might this model interact with or affect Medicare Advantage plans? And could this model alleviate any adverse impacts from the payment changes by enhancing primary care?
Sure. That's a great question and a complex one. I think, just there's been a lot of new programs besides Primary Care Flex that have come out from CMS. And I definitely think that a lot of these new programs are offering an opportunity for others in healthcare to experience or participate in a lot of the things that Medicare Advantage plans have been able to do over the years. I do think that it's going to impact Medicare Advantage, and I know that there's been talk in our industry about something called the Great Consolidation. And, we see it, I've been around long enough to see it a couple of times where, we see expansion and then we see the industry shrink some. And what that means is that maybe less and less startups, or there's startups that are coming out and then they're being bought and added on so that other larger companies add those capabilities. I think one of the things with V28, and there were a bunch of articles that have recently come out in the Wall Street Journal over the last couple of weeks, just around how, over the years, I think the rosters for Medicare Advantage have grown, but we do expect to see a decline. And we even see payers that are exiting the market and no longer offering Medicare Advantage, or others that are choosing to focus on, say, other lines of business like Medicaid. And I think that could be potentially challenging for patients and for members and beneficiaries, because the benefits, a lot of the things that were afforded by Medicare Advantage that I know seniors enjoyed might be lost. And so what I've heard in the industry is, it's an either or play. And we'll see, because bids, right, are about to come out here relatively soon. But some have said that there are health plans that are going to double down on benefits with the intent of enrolling as many beneficiaries as possible. And so making up for maybe the challenges that V28, that many are thinking V28 will pose, as well as other rules, but making up for it in sheer volume of enrolling lots of beneficiaries onto Medicare Advantage. The other play that I've heard that people are speculating or expect plans to take is that they will cut their benefits significantly. And so what that means is that less and less offerings. And I think you have this decrease in benefits, you have all these other plans that are encouraging other stakeholders to get in the mix. And what I think that we'll see is not only a consolidation across vendors, but a consolidation in the market as well, as people leave Medicare Advantage, or maybe less and less enroll with that opportunity and choose to get involved in a different type of offering.
That's a really good explanation. And also, I do agree with the fact that, yes, people are definitely going to move to the other plans. Obviously, they're not going to find disadvantages anymore, which also leads me to my other question, that the article, the Wall Street Journal article, also mentioned concerns about increased costs and reduced benefits for seniors, and due to the changes in Medicare Advantage. So if you could elaborate more on this, and how might the ACO Primary Care Flex model influence the quality and accessibility of care for those enrolled in Medicare Advantage, especially considering its focus on improving the care services?
Another really great question. I think I think one of the disadvantages will be, the loss of the benefits that we know. I think we're trading out one part for another. And while I believe so, the ACO Primary Flex encourages physicians to get involved with having that direct contract relationship with CMS. The difference between, at least what I could see, the large difference between ACO Reach and this Primary Flex model is really providing some upfront capital to help with the transition, because that was something that they saw with Reach, was that a lot of practices, it's not enough to just sign up and say you're going to take risk. You have to make sure that you have the infrastructure in place to take on risk and do it well. And many of the groups chose global risk, and they didn't necessarily have those systems in place that you find with groups that are at risk with Medicare Advantage health plans. And so I see Primary Flex as providing some of that capital to make those necessary changes. Now, we know that improving the relationship with one's physician definitely has an impact on health outcomes. And so in my mind, if we can get our seniors and those with chronic conditions in to see their physician more often, and there's actual behavior change where it's appropriate, like taking their medications, getting screenings when they're appropriate, or even implementing less costly interventions like behavior modification, a change in diet, adopting an exercise program, then I think that's great. And then, in that way, it benefits patients because, excuse me, health outcomes, right, are better from that. But also, too, I think, and having been in Medicare Advantage and in Medicare really since the beginning, um, I think the benefits that have come with that. So you figure there's all these great supplemental benefits, and we can't lose sight of the need to address, say, social determinants of health. And so providing, access to food, providing a transportation benefit, gym memberships. I know from being out in the field and speaking with members and with patients that they really enjoy those benefits. And it's, when we think about being proactive and preventative health and encouraging them to, eat a healthier diet. And I mentioned the food benefit, and especially for those that live in food deserts, or, having transportation to get to the doctor's office, or again, being able to go to the gym. Those aren't things that I could see that are accounted for in PCP Flex. And so I worry that, we're just trading one thing for the other. And what I would really like to see is an integration of all, because I think that there's a lot of benefits that Medicare Advantage offers. That was really the primary experiment. When government privatizes a business, it's trying to see if that privatized business, right, the intent is, or the thinking is that they could do it better. And I want to give a shout out to all those Medicare Advantage plans and the folks that have worked in Medicare Advantage over the years, because I think they have made it better. There's a lot more offerings. You have people getting their annual wellness visits. And I am one of those people that believe in, while I know that there are some people that have taken advantage of some of the programs under the HCC risk model, I do think that a lot of those programs did drive benefit in improving, how seniors intersect with healthcare. And it may be some time, right? We may need a little more time for effects to play out and have that, more longitudinal change of seeing improved outcomes. Could we have done it better? Are there things that could have been better? 100% absolutely. But I do think that, for all the negatives that you hear people complain about Medicare Advantage, there was a lot of positive that occurred. And I think it also provided a lot of learnings for the new programs that you see today. So I don't know that, I wouldn't say that either program is a win-win. I think that both offer very interesting options that could be very beneficial to patients. But ideally, I would love to see a blend, because I think that, it takes that different lens. You need that one-on-one relationship with your physician and to encourage that. But then there also has to be larger supports out there that are providing care to the patients, like I said, with those supplemental benefits. And I just think that asking our physicians to do that type of work is too much to ask. And to date, I would say that while a lot of our social agencies work very hard, I think again it's just difficult to provide the supplement that I think a lot of these patients need, that can be done through privatized business like Medicare Advantage health plans.
So from your responses, I think that you think that all of these programs are going to be very competitive to Medicare
Yes.
Advantage. And where do you think the industry is then headed? Is it going to be really competitive, or do you think that there's a slight chance that one policy may overpower the other?
Tough call. I have to get out my crystal ball for that.
No,
Um,
what I'm just trying to say is, where do you think in general the industry is
yeah.
headed?
No, I think it's an excellent question. And I think I'm both, if I have to, being fully transparent, I think I'm as curious as the next person, but then also too, I'm afraid for what my answer might be, only because I think competition is good. However, I worry, like I said, about, what it does to degrade some of the benefits of some of the programs that we have. Uh, we're already seeing payers exit the market in Medicare Advantage, and I know that there's been I would hate to see Monday morning quarterbacking. And no offense to those who like football. And apologies for the analogy, but I just know that a lot of health plans are choosing to focus on other lines of business, or they're exiting Medicare Advantage altogether. And honestly, I think that, that there were other ways to potentially respond. And so, there's opportunities to improve some of those other programs to mitigate or ameliorate any depreciation in revenue reimbursement that they may thought that they might find or feel in V28, or even what they might find in participating in the quality measures that have come out, or what they might have found from impact from, say, the final RADV rule. And so a full exit, or a shift in focus, it may make sense for the business, but I just think that they may have exited too soon. We'll see. I'm not in those positions, and so I'm sure that others will disagree with me. But I think that I think that they were a little premature in their decision. And then as far as the other programs, I think that again, I think that they offer a lot of benefit. I love that it empowers important parts of healthcare and stakeholders that are necessary to be successful and to participate, right? It's providing the opportunity for physicians, as well as for community-based organizations, for hospitals to now directly contract in these risk-bearing arrangements with CMS. But it's the same thing. It took time for Medicare Advantage to get to where it is today. And I remember starting in the beginning and, trying in the early 2000s to get someone to get an annual wellness exam. It was like unheard of. I mean, we were one of the first groups who was even doing home assessments and doing some of these programs. And it was really, when you think about an adoption curve, it takes time to get people, right, to come along and participate. It takes time to build in those structures, to build in the infrastructure that's necessary to manage risk. And so I think that there's still opportunity, and I think that's what we're going to find. And that was exactly right the experience in the first year of ACO REACH. And if you want to think back to GPDC and even, MSSP and all of these different programs, they're not perfect either. There's a lot of things that are to be desired. And, I know they're trying to make amendments to those to improve them. But I don't think that they're exactly where they need to be at either. So anyway, only time will tell, I guess.
Thank you, Doctor.